Welcome, everyone. I think we're very fortunate tonight to have a great speaker, Mark, give us this talk. Welcome, Mark. I'm just going to make some introductory remarks about Mark. Mark Harrier is the current Vice Chair of Research and a professor in the Department of Medicine. He's a senior scientist in clinical epidemiology program of the Ottawa Hospital Research Institute. He holds a Tier 2 research chair in venous thromboembolism and cancer from the University of Ottawa, and a new investigator award from the Heart and Stroke Foundation of Canada. In 2015, he was the recipient of the prestigious Dr. Michel Chrétien Researcher of the Year Award for his study published in the New England Journal of Medicine that improves care for VTE patients around the world. His clinical research is focused in VTE and cancer, including cancer screening, prevention, and management. He's currently the principal investigator on 4 peer-reviewed clinical trials funded by the Heart and Stroke Foundation and the Canadian Institute of Health Research. He is involved in numerous industry-sponsored trials as well. He has published significant systematic reviews and has had multiple international speaking invitations to speak on this topic of cancer and thrombosis. I don't think we can get a better expert tonight to give us this talk, so I know a couple of other people have joined on. Just a reminder, if you have any questions, I believe, Mark, you'd be okay with them asking the questions on the chat throughout the presentation, and maybe we can go from there.
Thank you very much, Anil, for the very kind introduction. It's really a great pleasure to discuss cancer-associated thrombosis. There's emergent data. It's exciting. It's leading to a lot of clinical questions. So hopefully over the next 60 minutes to 90 minutes, we'll be able to review the data and showcase this presentation in collaboration with Thrombosis Canada. So as David mentioned, the talk tonight is really to introduce you to the slide deck, walk you through the different components, and this will be available for you to use in your own institution afterwards. So feel free to download the slides afterwards and then use whatever slides or content that is appropriate for your own setting. So before starting, it's always important to have a look at disclosures. So these are my disclosures for tonight's presentation. As some of you know, my honorarium are always used for residents and fellows research and education, but there remain potential important conflict that you should be aware of. The program that we developed with Thrombosis Canada has received financial support from Sanofi Canada in form of an educational grant, but the sponsor did not have any say or did not reference anything in the setting, but Sanofi is marketing low-molecular heparin in Canada. So the content of this program was developed by a scientific steering committee from Thrombosis Canada. All faculty have directed any recommendation involving thrombosis are based on the evidence, and that is accepted with the profession, and all scientific research referred to be reported and used in CME adopted in support of justification of patient care recommendation. So it's important to keep that in mind before we start as well. So without further ado, although I was kind enough to, lucky enough, I should say, to be leading this program, there is a lot of work from a large number of different faculty members, including people in the medical oncology, thrombosis, internal medicine, and also people with primary care background, so that people that are seeing these complications on a day-to-day basis, and a good representation from east to west, just to make sure that the slides are representative of clinical practice in Canada. And therefore, the learning objective, depending on how you want to tailor your talk when you're using the slide deck, can be 5 of them. So the first one is obviously understand the risk of venous thrombosis in the cancer patient, discuss best practice options for cancer-associated thrombosis, really tailoring anticoagulation management based on subgroups, what's the underlying risk of recurrence and bleeding. Sometimes we have to make a decision about hospitalization or not when patients are presenting with PE. You saw that one of the faculty was Eddie Lang from Calgary, an emergency room doc, obviously Anil Chopra as well from the emergency room. So we have some slides in order to help guide clinicians on making decision about hospitalization or not and what are the tools available. Discuss the risk factors associated with increased risk of VTE and major bleeding episode in the setting of cancer-associated thrombosis. And obviously the overall goal is to provide better care to cancer patients with suffering with these complications and identify best strategies to decrease the risk of recurrence and avoid any bleeding complication is the overall aim. So the presentation will start with just an overall overview of cancer-associated thrombosis in order to make sure everybody's starting on the same foot. And defining the terms is sometimes helpful depending on the audience or when we tailor the presentation. So just having an overall discussion about thrombosis in general, venous thrombosis, specifically deep vein thrombosis and pulmonary embolism, the two ends of the same tube. These can happen not only in lower extremity, like proximal lower and deep vein thrombosis, but in the cancer population, they often get in the upper extremities as well due to cancer-related. Often they need central venous catheter for chemotherapy deliverance or, chemotherapy, for example, or transfusion, for example. So these are also very common. And obviously throughout the presentation, just to reinforce that when we talk about CAT, it's going to be cancer-associated thrombosis, referring to all the different clots that are available. And this is important to create awareness and have a discussion because the incidence is very, very high in the cancer population. We're talking about a 4- to 7-fold increased risk of VTE in cancer patients. Thromboembolism is the second leading cause of death, so arterial and venous clots, and associated not only with mortality but significant morbidity. Cancer patients are living longer and longer, and they have often post-lytic syndrome and chronic dyspnea associated with a VTE complication, especially pulmonary embolism. So it's something that is common, and it's something that deserves attention because associated with morbidity, but also mortality. And why cancer patients are so commonly affected by this condition? Well, it's easy to figure out. When you talk about cancer patients, they have all the different factors from the Vicos triangle, right? So they often have venous stasis because they're often in bed requiring hospitalization for complication or post-surgery, for example. They have local tumor compression to veins, and they often have vascular injury because we're inducing biopsy, we're doing surgeries on these patients. And then often they have hypercoagulability from the tumor itself, like we often think about pancreatic cancer, stomach cancer, gliomas that are hypercoagulable, but also other types of tumors that are associated with treatment that might lead to significant risk factors as well. So it's a frequent complication. It's a complication that we see early on. So often upon the diagnosis, when they start therapy, they have a fourfold increased risk to have a diagnosis with cancer treatment that will increase significantly. But through the cancer journey, but certainly when we see that more frequently, it's certainly in the early stage of cancer-associated thrombosis. So it's just important to keep that in mind that there's different risk factors associated with the disease itself, but also the underlying treatment. So let's delve into the underlying, complex and controversial area about treating cancer-associated thrombosis. There's been a lot of data over the past 10, 15 years, and there's ongoing data, and recently some more data comparing the direct anticoagulants to low-molecular heparin have emerged, and therefore, giving us more tools that we can use in our pockets to treat these cancer-associated thrombosis in the arsenal of what we can do. So that's exciting. If we look at clinical practice guidelines right now, when you look at, independent if you're looking at the American Society of Clinical Oncology, if you look on Thrombosis Canada website, Leading Consensus, and if you look at the ACCP, the American College of Chest Physicians, they would recommend that low-molecular heparin for a treatment of established DVTs and PE should be done with low-molecular heparin for a time being for a treatment duration of 6 months for the majority of the clinical practice guidelines. Some of them would say 3 to 6 months. And things are changing. So now we have direct anticoagulants that have published data and ongoing studies as well, and that will lead the field further, and we'll be able to, or we'll have to tailor anticoagulation management accordingly. But the rationale for having the clinical practice guidelines currently recommending low molecular heparin is because, as you know, we have a number of studies, 5 or 6 randomized controlled trials, and I'll come back in a minute, that have firstly looked, so the first step was to look at low molecular heparin versus vitamin K antagonists or warfarin. So that's particularly challenging in the cancer population because you have drug-to-drug interaction, drug-to-food, cancer patients have nausea, it's somewhat difficult to control. And when you're looking at the data underlying what we see from the recommendations from clinical practice guidelines, what we can see is when, independent of the study you're looking at the different types of low molecular heparin, can be enoxaparin, dalteparin, tinzaparin. When you're comparing low molecular heparin to vitamin K antagonists, you have an overall risk reduction in the risk of having a second clot despite anticoagulation of about 50%. And that's usually the efficacy measure we like to use for venous thrombosis trial. When you look at major bleeding, because obviously we're looking at blood thinners, when you look at the flip side of major bleeding, there's no difference between low molecular heparin and vitamin K antagonists, and therefore, the current clinical practice guideline that is shown on the previous slides really recommends low molecular heparin when you have to make a decision between low molecular heparin and vitamin K antagonists. Now, some of these also had recommendations about DOACs. Remember, some of these recommendations are relatively old, and the reason why they had grade 2B or grade 2C recommendations for use of DOAC for cancer-associated thrombosis is because most of the data until then were derived from the acute treatment trials comparing direct oral anticoagulants to vitamin K antagonists, and we really didn't have too much direct oral anticoagulant versus low molecular heparin. But that has changed now. So maybe it'd be a good time now to have a reflection about looking at the data we had, DOACs versus low molecular versus vitamin K antagonists, and looking at the DOACs versus low molecular heparin as well. So when we look at the DOACs versus vitamin K antagonists, remember these were subgroup analysis of the acute treatment trial, and investigators, when they randomized patients in these clinical trials, they realized that they either going to put their patients randomized to one of the DOACs or vitamin K antagonists. And when we looked at these subgroups, we realized that a lot of these patients were not really high-risk patients. They were probably low risk of recurrence, low risk of bleeding, and therefore not necessarily representative of the clinical practice. And that's why people initially, when we saw these subgroup analysis, were not overly convinced, and that's why it led to grade 2B and grade 2C recommendations. This is a systematic review looking at the subgroup of cancer patients comparing the direct oral anticoagulants to vitamin K antagonists. So again, these are the acute treatment trial. Some of the patients in there, although about 5 to 10% had a diagnosis of cancer. When you look and you do the pooled estimate, when you compare direct oral anticoagulants to vitamin K antagonists, and when you look at the risk of recurrence or efficacy comparing direct oral anticoagulants to vitamin K antagonists, you can see from the forest plot that it seems to be favoring direct oral anticoagulants. However, you can see that the 95% confidence interval are overlapping with one, and therefore it was not statistically significant, but hypothesis generating that if you're using DOACs in this selected population, maybe low-risk population, you seem to be having a lower risk of recurrence compared to vitamin K antagonists. And again, when you're looking at these subgroups again, but looking not only at the efficacy, but when you're looking at major bleeding, the safety of this, it could be major bleeding on the panel A on the top. When you're looking at major bleeding would be bleeding from a critical site, or bleeding from 2 units of packed red blood cell, for example. And then clinically relevant non-major bleeding are those that don't necessarily meet the criteria, but not the major criteria for clinical bleeding, major bleeding, But again, these are important for patients because they will have, patients will seek medical attention for them. They'll have to call their doctors. They'll have to have procedures for them. So these are important to consider. But independent if you're looking at major bleeding and clinically relevant non-major bleeding, when you're comparing the direct-oral anticoagulants to vitamin K antagonists, seems to be favoring the direct-oral anticoagulants as well. However, as mentioned, the forest plot is, the pooled estimate is crossing 1. There's a network meta-analysis that try really to compare low molecular heparin with direct-oral anticoagulants or vitamin K antagonists as well, trying to, when we didn't have data, sometimes we have to do indirect comparisons to try to generate a hypothesis and hopefully provide some guidance to clinicians. So again, on table A, when you look at on the top one, comparing low molecular heparin to vitamin K antagonists, seems to be favoring low molecular heparin. Comparing the direct-oral anticoagulants to vitamin K antagonists, very similar to the data we've seen before. And when we look at major bleeding, low molecular heparin versus vitamin K antagonists, as mentioned, there's no real difference. When you're looking at direct-oral anticoagulants plus vitamin K antagonists for cancer-associated thrombosis, seems to be favoring direct-oral anticoagulants. That's why, at least it gives you a little bit of the rationale why clinical practice guidelines up until today, I guess, is favoring low molecular heparin first. 2B recommendation compared to vitamin K antagonists based on the data I've shown you. And then 2C recommendation, because although there's a little bit of data, it's indirect. And when you're comparing direct-oral anticoagulants compared to vitamin K antagonists, maybe some slight advantages there. And therefore, there's certainly a use in certain patients that might be at lower risk of having recurrence or having risk of bleeding. But, since then, 2 large randomized controlled trials have been presented at the American Society of Hematology last year and published since then. The first one is the Hokusai VTE cancer trial that was published in the New England Journal of Medicine in February. And that's comparing 5 days of low molecular heparin, any low molecular heparin that the investigators see fit, versus dalteparin at a dose of 200 units per kilogram for the daily for the first month, then dose reduction to 150 units per kilogram daily thereafter for at least 6 months and up to 12 months. So you can see this was an open label non-inferiority trial. They were hoping to have over 1,000 patients, and they did, 1,046 patients. And then they include patients with symptomatic and incidental VTE. Incidental VTE is more and more common. We see that all the time when patients are ongoing imaging for cancer staging, for example. So these patients who enroll, and we'll have to have a look at the baseline characteristics as well to make sure this is applicable to the patient population. These patients were randomized to the 2 interventions that I mentioned, and as I mentioned, it was for at least 6 months, a minimum intent of 6 months and up to 12 months. And what's interesting and what's important to remember from Hokusai VTE cancer trial is the primary outcome is different than what we've been discussing and what we're usually seeing in VTE trials. So it was not a trial looking at efficacy and safety, so recurrent VTE despite anticoagulation or major bleeding on anticoagulation. It was really a composite outcome of recurrent VTE or major bleeding during the first 12 months. First event of recurrent VTE and major bleeding independent of the randomization. So that's important to keep in mind because when we look at the primary endpoint, that's the non-inferiority criteria, but you're probably going to ask, Mark, I really want to know what are the components of this as well. What's the risk of recurrent VTE? What's the risk of major bleeding? So, it was an open trial, but it's important to remember that it was a probe design, so there was an independent blind adjudication committee for all suspected outcomes. And it's also important that they wanted to look at the severity of major bleeding. That's sort of a new thing that they've implemented, and we can have a look and have a discussion of what does it mean in clinical practice and is it applicable to our patient population. So obviously the first step when we're looking at a trial is to make sure we look at the baseline characteristics to make sure it's applicable to the patient population we're seeing. So the age is around what we see for VTE-related trials. What's important to, I think, just to show the severity or if it's applicable to our clinical practice, metastatic disease, about 50% in both groups. And what's also important is the additional risk factors that are associated with maybe adverse events or things that we see not infrequently in cancer patients like renal dysfunction, thrombocytopenia. These are important to just try to tease up if this is applicable to a sick or not so sick population, and then can we extrapolate these results when we see patients in clinical practice. Now, obviously, as I mentioned, the direct anticoagulants have less drug-to-drug interaction compared to vitamin K antagonists, but they still have drug-to-drug interactions, and that's the reason why the type of chemotherapy was reported. Just to give you a sense as well as, you know, is it applicable to my patient population or not? So having a quick look at it, some people or medical oncologist colleagues, when they look at it, they said I would have liked to see a little bit more bevacizumab, but it is what it is, and then obviously there's no checkpoint inhibitors or immunotherapies in that list, so that's important to keep in mind. And we'll talk about the drug-to-drug interaction and what's the clinical importance or relevance down the road, but these are important to keep in mind when we're making treatment decisions. So when we look at the primary outcome measure, you know, comparing again a composite outcome of recurrent VTE and major bleeding, comparing folks receiving direct anticoagulant with edoxaban or dalteparin for low-molecular heparin, you can see here that the edoxaban was not inferior to low-molecular heparin with an hazard ratio of 0.97 that was statistically significant. But again, it's hard to interpret that in clinical practice because we tend to think about efficacy and safety, so it's always good to look at the components, and it's always good to look at things over 6 or 12 months and per protocol as well. So this is just another slide reminding you, if you like to look at the number of events, more specifically with the associated rates that led to the hazard ratio of 0.97 with the upper bound of the 95% confidence interval of 1.36, and the predefined upper bound was 1.5. We'll have a discussion if this is high or not so high for VTE-related trials, but this was what was defined. So looking at the different components now, we're getting excited. It may be non-inferior, but what does it do for recurrent VTE and major bleeding? Is it going in the same direction? Well, interestingly enough, it's going in different directions. And you can see on the left-hand side, this is the risk of having a recurrent event despite anticoagulation. You can see that folks on edoxaban seem to have a lower risk of recurrent VTE over time. The two curves seems to be separating after 3 months, with an associated hazard ratio of 0.71, and that was not statistically significant. The upper bound of the 95% confidence interval crossed 1. And on the right-hand side, when you look at that major bleeding, you can see that the folks on edoxaban also had an increased risk of major bleeding episode with an hazard ratio of 1.77, and that was statistically significant. And therefore, so when you're looking at the two different components, the direct anticoagulant with edoxaban was associated with a lower risk of recurrent VTE, but that came at a cost of major bleeding. And when you look at the KM curves, you can see that the two curves are separating from the day of randomization. Now, obviously, as I mentioned, this was an open label randomized trial, so patients and clinicians knew if they were randomized to the low-molecular heparin or to the direct anticoagulant, and therefore that led to somewhat of a difference in treatment duration. There's almost a month difference between folks taking edoxaban versus dalteparin. That was statistically significant, and you can see that less patients receiving the low-molecular heparin completed the 12 months compared to the direct anticoagulants. And the number one reason for discontinuation was patient's preference. So after 6 months, they could switch to an alternative agent. So that's important to keep in mind because that might make a difference when we do interpretation of these results, of course. And then we need to keep that into consideration. So we talked about recurrent VTE, recurrent bleeding. We talked a little bit about what are the subcomponents of these, because recurrent VTE can be recurrent DVTs or PEs. You can see that when you look at the risk of recurrent VTE over time, this was really driven by a difference in recurrent deep vein thrombosis. There's almost no difference in recurrent PE over time. And when you look at major bleeding, We also like to look at clinically relevant non-major bleeding because, as I mentioned, these are bleedings that are important to patients and clinicians because they tend to call you and you have to manage these bleeds. And you can see that it was somewhat similar to what we've seen with the major bleeding episode. And there's more clinically relevant non-major bleeding, 14.6% in folks receiving edoxaban compared to 11.1% in dalteparin. Obviously, this is not statistically significant difference, but a trend and hypothesis generating as well overall. When you combine major bleeding, clinically relevant major bleeding, well, there's no surprise because there's more major bleeding, clinically relevant non-major bleeding in folks taking the direct anticoagulants, and that was somewhat similar. So 18.6 versus 13.9% in it, and that was statistically significant. So, we're all clinicians, we're pharmacists and doctors and nurses and healthcare providers, and the first thing we don't want to do is cause any harm. So one of the thing that comes to mind is if there's more bleeding and more clinically relevant non-major bleeding, is there any way that it can, look at the granularity of the data and come up with risk factors associated with them? Well, it looks like the discrepancy in major bleeding, we'll come back to that, was upper GI bleeding. It looks like a large majority of the patients with upper GI bleeding had GI tumors and didn't seem to be related specifically to stomach or GE junction types of tumors, but really GI tumors from the whole GI tract, including, for example, colon cancer, pancreatic, and stomach and GE junction, so the whole thing. They couldn't really, couldn't really tease out, is it because there's intraluminal defect or not? Maybe folks on colon cancer, for example, with their 5-FU or long-term chemotherapy eventually have erosions that leads to upper GI bleeding as well. When we look at overall survival, that's important to look at because it gives you a sense of how sick the patients were. There's no difference between the two arms. But when we look at the 6 months overall survival and the overall survival, it gives you a sense of how sick the patient was, and it's helpful to compare it to the previous studies comparing rheumatoid heparin to vitamin C antagonists as well, just to see if these event rates are aligning with what one would expect. So the second clinical trial that was published is a pilot trial. So remember, we said 1,046 patients for Hokusai VTE trial. Now we have a select the pilot trial looking at rivaroxaban versus dalteparin. So much lower scale trial. We're talking about 400 patients. It was a prospective, open label, randomized pilot trial, mostly, but not mostly, but done in the UK. Patients were randomized to rivaroxaban, so 15 milligrams PO BID for 21 days, then 20 milligrams PO daily thereafter, and then it was for 6 months. And then patients initially, they had a second randomization after 6 months to try to see if they could tailor length of anticoagulation. Do we need to continue long-term or extended duration for these patients or not? But unfortunately, they had a really hard time recruiting patients, and they had to abandon the second randomization. So what we're going to be discussing, and what was published in the JCO in the spring, is only the first 6 months. So when patients were randomized to rivaroxaban or dalteparin at the same dose we talked about. The primary outcome measure was different than the Hokusai VTE. They didn't use composite outcome measure. They used the usual one of recurrent VTE and major bleeding, and they also looked at clinically relevant major bleeding, and we'll be able to compare it to those both. On this particular slide, I use it basically to remind ourselves that there was initially 2 randomization. Initially, the sample size was 530, because again, this is a pilot trial, so it wasn't really powered to detect a difference between the 2 treatment arms. It was powered to have a point estimate of recurrent VTE in the rivaroxaban arm and have an upper bound of 8% for the 95% confidence interval. And we realized that the 8% was really precise, but 9% would be reasonable. And therefore, they were able to decrease the sample size from the 530 you're seeing here to 406 that will be reported. When you look at the baseline characteristics, It's very similar to what we've seen in patients with Hokusai VTE. The main difference really is that if you look at on the last line, when you look at qualifying VTE, so patients coming in to be randomized into the trial, you're seeing that about 50% of them had incidental PEs, and that's more than what was included in the Hokusai VTE trial. It was about a third, remember, and therefore that may or may not make a difference, but that's one of the biggest difference between the baseline characteristics for SELECT-D and Hokusai VTE is the different proportion in qualifying VTE. And when you look at the Kaplan-Meier curves between the two, we'll look at the event rates in a minute, but again, we're looking at the primary outcome for efficacy, so recurrent VTE within 6 months despite anticoagulation. You can see that folks receiving rivaroxaban had a lower risk of recurrence compared to dalteparin. Again, the two curves seem to be separating after a couple of months of being randomized. And when we look at the more granular about the risk of recurrence for the initial 6 months, you can see that, it was 8. The numbers are much smaller, but 8 in the rivaroxaban compared to 18 in dalteparin arm, most of which was related to DVTs and PEs, so 11 versus 4%. Keep in mind that for SELECT-D, unlike Hokusai VTE, when they looked at recurrence, they also looked at unusual site thrombosis. So there's a few patients that had, splenic vein thrombosis, for example, that was included in there. But nonetheless, when you look at the event rates, there was 11 versus 4%. When you look at the upper bound of the 95% confidence interval for rivaroxaban, it was 9. That's why the trial was powered to detect. And that was to lead to, the next step of having a phase 3 trial and having point estimates that are reliable to calculate the sample size accurately. So, their conclusion is that rivaroxaban is associated with a relatively low rate of recurrent VTE. It's hard to compare the two arms because it's much a smaller trial. It was a pilot study as well, so not really designed to do any comparisons. And when we're looking at the efficacy, it seems to be somewhat similar to what we've seen in patients randomized in the Hokusai VTE trial. When you look at the flip side, the risk of major bleeding, well, it was somewhat similar again when we looked at, if you look at the Kaplan-Meier survival score and the event rates in the table, you can see that folks receiving direct anticoagulants with rivaroxaban were more likely to have major bleeding and clinically relevant non-major bleeding compared to those receiving low molecular heparin. So again, the same signal that we've described before, that some of the direct anticoagulants seems to be associated with a lower risk of recurrence, associated with a higher risk of major bleeding episodes. Now, interestingly, these are just a few events because it was a smaller trial, but when they looked at the event rates of which patients tend to bleed more, they had a lot of GI patients, and in a clinically relevant non-major bleeding, a lot of folks with urothelial type of tumors as well. And that will be reflected in guidance statements that were made to try to help clinicians to tailor their anticoagulation accordingly. And therefore, that's important to keep in mind. It's also important to keep in mind that during the study conduct, the DSMB, or Data Safety Monitoring Board of the SELECT-D trial, asked the investigators to stop randomizing patients with upper GI tumors because they saw a difference in the risk of major bleeding overall between the two treatment arms. And again, when we look at the 6-month survival, no difference between the two treatment group. And again, something that is helpful to use to compare to the other studies to look at the overall severity or how sick the patients randomized were compared to one another. Most of the folks that died of progressive cancer. 2 folks in the SELECT-D had fatal PE as their recurrences. And of course, as soon as you have 2 randomized controlled trials, you'll have a systematic review that it's already done. And you can see that if you put the 2 studies together, if you look at the top panel A, that would be risk of recurrent VTE. The lower panel will be major bleeding. You can see that the 2 studies seems to be in the same direction anyway, seems to be associated with a slightly lower risk of recurrence when we're using DOACs. It is not statistically significant, but associated with an increased risk of major bleeding. That is statistically significant when you pool the results of the two studies together. So then the next question to that is, what to use and how to tailor anticoagulation accordingly when you're facing patients with VTE in your emergency room. You need to make decision if they need to be hospitalized or not, what type of therapy they're going to start. Are they going to start parenteral low-molecular heparin? They're going to start them on oral anticoagulant. Do they need to have admission? And some of the slides that we've built in with our emergency room colleagues is to try to, provide some data or some guidance on when to hospitalize patient, what is used, what has been used and shown to be helpful to clinicians. So estimating what's the risk of having an adverse event, and for folks that have really a higher risk, and maybe considering hospitalization to mitigate these risks. And what can be done? Well, there's a number of different factors, and we'll be able to engage into discussion, but the PETSI score has been used, the simplified version as well. And there's some biomarkers that can be used, as well as echocardiography that might be helpful to decide if a patient should remain for observation or can be safely discharged home. These are, just a refresher of the different characteristics that are used in the PETSI and the simplified PETSI, but it's also a reflection that when emergency room docs and clinicians are making these decisions, they're really using if the patient is stable or unstable, using heart rate, for example, respiratory rate, these things, systolic blood pressure, O2 saturation, really to make a decision if the patient has an indication to anticoagulation or not. Now, it's important to tailor anticoagulation, the management of patients with acute cancer-associated thrombosis, and I think with after having a reflection of what we've seen with SELECT-D and Hokusai VTE, I think there's certainly some key learning points in summary that one can make. So we should probably, looking at the data, avoid the direct anticoagulant in certain GI tumors, potentially urothelial malignancies as well. Folks with nephrotomies too, they've certainly been associated with higher risk of clinically relevant non-major bleeding and major bleeding as well. When you look at we didn't have the time to go into certain details, but there's certainly times, or when you look at the appendices of these trials, there's certain risk factors that were associated with a higher risk of bleeding when patients were on direct anticoagulants. So thrombocytopenia is one of them. Some renal dysfunction is one of them. This is controversial, of course, and open to discussion. Just reporting what's been shown to be associated with a high risk of having bleeding and giving some justification of why we make certain decisions. Obviously, it's important to consider drug-to-drug interaction when choosing direct anticoagulants. And, patients at high risk of bleeding, of course, if they had previous major bleeding episode, if they have intracranial hemorrhage or intracranial disease from metastatic or primary tumors, these are all things that we need to consider. Patient's preference, we'll come back to that. It's certainly on the top of the list, and it's important to have a discussion with our patients because they don't necessarily see themselves as being clot patients, but more as cancer patients. So they want to make sure that the treatment is not going to be later anti-cancer therapy, that the treatment will be providing is safe and effective, but also that they can have a route of administration that is to their liking. And that comes at the third place. So if a patient needs oral versus parenteral or vice versa, they'll be open to do that depending on their underlying risk factors and what you feel is the most appropriate treatment. But it can also go from one to the other. There's certain time in the cancer journey where a parenteral drug might be more appropriate, and then certain times where an oral drug might be more appropriate as well. But it will be important to look at our patients on a regular basis and make sure that we follow them over time. Coverage is a big issue in Canada, so that will factor in our treatment decision. Extreme of body weight as well. As you know, the ISDH is recommending to be careful, for example, if you're over 120 kilograms or less than 40 kilograms with direct anticoagulants. That just needs to be considered and kept in mind. I told you that I would come back to drug-to-drug interactions, and this is just a reminder that the direct anticoagulants, although they have less drug-to-drug interaction compared to vitamin K antagonists, they certainly are metabolites of the CYP3A4 metabolism and pathways in the liver, and glycoprotein P transport in the gut. And this is just to show you a few examples of chemotherapies that have been associated with interacting with these different pathways that can lead to increase or lower the level of the direct anticoagulants, but also, for which the clinical relevance is unknown. Is it theoretical or actually has clinical relevance or not? Is it leading to more chemotherapy toxicity or less efficacy? There's still a lot of unknowns, so I'm not saying these are all completely clinically important, but important to be mindful of them, and especially if they come into combination, and if you have renal dysfunction, for example, these are important to keep in mind because they may make a difference and lead to different complications. And patients' preference and coverage is important. I mentioned the different things that cancer patients think about, and certain cancers will be associated with very emetic type of chemotherapy, may be associated with, some patients might have needle phobia. That might direct you to more of an oral agent versus a parenteral agent, but you'll need to really tailor anticoagulation based not only on the patient characteristics, but also their preference, what they're going through right now, and the coverage associated with it, because cost is a big factor when patients are undergoing treatment. Now, I told you that this slide deck tonight, we're just looking at the slide deck, seeing what's available. You can use it when you in your own center if you'd like, or if you're doing a presentation on CAT. And it's sometimes hard, as you know, to present to different groups. Sometimes we're presenting to a nursing group, a pharmacist group, a physician group, or allied healthcare group. Sometimes we're talking to patients. And so we provided a little section here on patient education as well, because we all know that VTE and ATEs, arterial or venous thrombosis, are not on the top of the mind of patients. We don't necessarily know the signs and symptoms associated with them. When they have cancer-associated thrombosis, there's some risk reduction strategies that can be discussed with them as well. Discussing, for example, what are the underlying risk of recurrence or bleeding, that the importance of being compliant with their medications, the reasons why they're actually taking this, why they need to be compliant, what's being compliant, trying to provide them with tools so that they can, track sometimes how they take their medication, how to think about taking the medication, to bring the medication when they come to see us, and then reviewing the low molecular heparin injection techniques, because that can make a big difference in how it's delivered and the pain associated with some of the injections sometimes. So reviewing the techniques, make sure they're doing it well, and often, most of the time when it's well done, it's associated with no pain at all or very minimal discomfort. So these are important. Talk about the signs and symptoms of recurrence of their patients. Sometimes when they were diagnosed, it was incidental in nature, so they may or may not know the signs and symptoms of DVTs and PEs. Create awareness, let them know that if they have them, they need to seek medical attention or come by to the office if possible. And obviously, educate them about bleeding, because we saw that it's a frequent complication. They need to know, if they have stools and if they have blood in their stools, or melena stools, or black stools, or if there's blood in the urine, then know they should be contacting us to make sure that we can reevaluate and tailor anticoagulation accordingly. And when patients have a reasonable understanding of the risk factors and the preventative measures, they're often really, they take ownership, they're aware of why this is important, they are more compliant, and clear, consistent patient education makes it very beneficial for both the physicians and the pharmacists and the patient in avoiding adverse events. And I'm not sure if you're using this already in your clinical practice. I use it all the time in mine. I make photocopies of them, but this is the type of information I provide to them so they understand. It's even hard for them sometimes to understand the difference between a venous and an arterial clot. So giving them at least a link to the resources through the Thrombosis Canada website is very helpful for them to sort of understand all this. Now, this is the part of the section or part of the presentation that is associated with reviewing the data. There's a few cases, so we added 3 cases in the end just to, put the data that we've talked about in the forefront and having a few what-ifs and trying to complicate them and so that you can tailor the cases to the need of your audience. And if that is okay, then maybe I'll go through the case studies. And if there's
Mark, can I just ask, is there anybody on the line that has any questions at this time? I don't notice anything posted on the chat. Just for a second, if anybody has anything on the phone to ask Mark.
Sure.
Okay, I had a couple of questions, and I think you actually put it together, Mark, in some of the cases I've seen the slide deck. So why don't you go ahead and continue?
Sure. It's clear as mud. So let's continue the case studies, and maybe we can put everything we've learned into cases and then generate a discussion if needed in the end. So thanks, Anil. So the case series, 3 different cases. One made by Vicky Tagalakis, one of our general internists doing thrombosis in McGill, one done by our medical oncologist, Normand Blais, and one made by Mary DeCurlis, one of our general practitioners of oncology in Ontario. So I'll go through them. Maybe it'll generate discussion or not, and then we can pause for some of the questions. So Mrs. RS is a 54-year-old high school teacher, married, mother of 2, past medical history significant for hypertension, hypercholesterolemia, both well controlled. Her BMI is 31. She has basic blood work with CBC, renal function, liver function, all within normal limits. She has a diagnosis of metastatic colorectal carcinoma. She's receiving palliative chemotherapy with FOLFIRI and bevacizumab in a stop-and-go fashion. So sometimes she might have to have chemo holidays and then resume when the tumors are more active. She presents with a painful, swollen, red lower left limb. The ultrasound confirms a proximal left popliteal deep vein thrombosis, so cancer-associated lower limb deep vein thrombosis in the setting of metastatic colorectal carcinoma. And then we can engage the audience with how would you best treat it? Would you use one of the low molecular heparins? There's 3 different choices, and why. Would you prefer to use vitamin K, like low molecular heparin bridging the vitamin K antagonist, and generate discussion around that, or treat it with 5 days of low molecular heparin with edoxaban, or to use rivaroxaban alone? And that's a good case because it's metastatic colorectal. We know GI tumors tend to bleed a little bit more. Should we use low molecular heparin versus rivaroxaban? Can generate a very nice discussion. And then we have added a few what-ifs. So, for example, what if her renal function is decreased and her creatinine clearance is 29 cc's per minute? Is that changing what you do? Are you more keen on using a direct oral anticoagulant or a low molecular heparin? If you're using a low molecular heparin, you're more keen on certain brands versus others. Would you do dose modification if you're using certain low molecular heparin? So engaging the audience about what to do and what you do in clinical practice, because when you present these slides, the audience want to know, as the local expert, as the national expert, what you think and what you'd recommend, because they need to have these types of things. And then we added a few additional slides. So, for example, anticoagulation, renal dysfunction. Obviously, full dose anticoagulation needs to be fully, be careful when the creatinine clearance is less than 50 cc's per minute. That's moderate renal dysfunction. You need to be very careful if the creatinine clearance is less than 30 cc's per minute, because that would be severe renal dysfunction. Some product monograph for a certain brand of low molecular heparin would go lower than that. Some brands would also have dose reduction strategies. Engaging the audience, would it be something to do? Can you do or not, depending on your setting? Can you do anti-10A monitoring or not? And reminding people that low molecular heparin should be used with extreme care in patients with end-stage renal disease requiring dialysis. There's some accumulation long-term, remember, where you're going to use it long-term. So certain studies have shown that, a 20% dose accumulation that is hard to predict. the direct anticoagulant would be in the same boat. We could have a discussion about the direct anticoagulants on hemodialysis. I saw one of the questions about that, and I'll come back to that in the question period, for example. We need to be careful as the creatinine clearance is less than 30 with direct anticoagulants. It will depend on the product monograph. I know there's folks from Canada here. I would say that the rivaroxaban has dose reduction all the way down to 15 cc's per minute. Others from Europe and elsewhere in the world, I saw that it will depend on the product monograph and what we believe the data is. And I'll be happy to discuss that further. But in the setting of cancer-associated thrombosis, really what we have is subgroup analysis of some of the trials that compared low-molecular heparin versus vitamin K antagonists. So subgroup analysis of the CLOT trial, for example, looking at VTE and major bleeding in patients with creatinine clearance of less than 80. Remember when we did the CLOT trial was in 2003, so we didn't really have creatinine clearance. We had creatinine thresholds instead, so we needed to recalculate them. But you can see that when you look at the risk of recurrent VTE associated with a lower risk with dalteparin compared to vitamin K antagonists, a slightly higher risk of major bleeding that was not statistically significant, so somewhat similar to what we had before. And subgroup analysis in the CAT trial looking at recurrent VTE and major bleeding, comparing thrombocytopenia with low-molecular heparin seems to be very similar, looking at from a risk of recurrent VTE point of view, but when you look at major bleeding, seems to be favoring daiteparin compared to vitamin K antagonists. So this is the data that we have specifically in cancer-associated thrombosis. I'm sure we'll have more data when subgroup analysis of the Hokusai and the CYP3A4 and the other trials will be available as well. But that can help to generate discussion with your audience and tell them exactly where the data is coming from and what you would actually recommend this particular time. So the other what if she's receiving a Juven pulse block?
Excuse me, Mark.
Yeah.
Do you want to just address the question in the chat right now or save it till the end?
I'm happy either way.
Yeah, I just thought because you're talking about all the renal stuff, so this is a question I find everybody's interested in. It seems to be a general question by Mohammed. What would be the best choice in patients with end-stage renal disease, and particularly patients on dialysis, which could, I guess, be similar or different populations? I'm not sure if that question is addressing the all patients and or the cancer patients, but it's a very fascinating question.
Right. It's a fascinating question with a lot of data, so maybe I'll start with the non-cancer patients because I'm sure the data is coming from the recent data from apixaban in patients with renal dysfunction. There's paper in circulation that show that apixaban in folks with atrial fibrillation, not VTE, but in the U.S., patients on apixaban on hemodialysis versus vitamin K on hemodialysis for different CHAD score is associated with a lower risk of ATEs and lower risk of bleeding as well. They're looking at different subgroup comparing at low dose apixaban versus regular dose apixaban. Didn't have enough patients to specifically look at these. However, it's important to keep in mind that this is product monograph in the United States. There's PK and PD studies that are saying that if you're looking at apixaban in patients on hemodialysis at a dose of 2.5 BID, then after 8 days, the peak and trough level are similar to a normal patient, so someone that is not on hemodialysis. However, if you look at a patient that is receiving apixaban 5 BID on hemodialysis after 8 days versus the levels of someone that is not on hemodialysis, then the levels are 3 to 5 times higher. So it's important to keep in mind that, there's not a lot of data for the direct anticoagulants on hemodialysis at this point in time. It's debatable if they need anticoagulation or not. If you're stuck and you can't really use vitamin K antagonists because of calcitomaxis or something like that, you want to use a direct anticoagulant for an AFib indication, then maybe an apixaban 2.5 BID could be an off-label use of the medication for sure. Now, if you look at the different low-molecular heparin, and if you're looking at VTE in general, well, it always depends on where you're at from the clot, right? So the risk of recurrence and bleeding will be always highest during the first month as you go along over time, this will decrease significantly over time, and therefore you may or may not need to use full dose anticoagulation. You can get by with intermediate dose or prophylactic dosing. And sometimes when hemodialysis patients are in, well, it's easy to do blood levels, and then maybe it'd be easier to follow anti-10A level as well, something that you could do with the direct oral anticoagulants. So all that to say, Neil, is there's not a whole lot of data. There's some little clues that maybe low-dose DOAC might be reasonable if it's atrial fibrillation for an indication. Low-dose low microrate heparin might be possible as well. And then maybe following these with anti-10A levels might be desirable.
So, Mark, when you say low-dose low molecular heparin, do you mean like half dose or some other dose?
Well, if the patient needs to be on long-term, then the prophylactic dose is probably more than reasonable. But if it's 2 or 3 months since the index event, then maybe decreasing the dose a little bit might be desirable. So an intermediate dose for the early part when patients are at high risk of recurrence. When they just need extended duration, then it's I think prophylactic dose might be more than enough.
Great, thanks.
Thanks, Anil. And then again, thanks, Mohammed, for your question. So what if, the second what if that we put there is just, thrombocytopenia. Do you keep them on the same? Do you prefer to use a DOAC or vitamin K antagonist? Do you continue with low microrate heparin, or do you prefer to use low microrate heparin? What's your threshold? So obviously it's just having a discussion about heparin-induced thrombocytopenia. Make sure it's not in the first 5 to 7 or 10 days. You need to keep that in mind. If not, balance the risk. If you think it's therapy-related from the chemotherapy, for example, balance the risk-benefit of anticoagulation. Most people would have no problem with full-dose anticoagulation when the platelets are over 40 to 50, and there's recommendations, or I should say guidance, from the International Society of Thrombosis Hemostasis that has changed slightly. It was initially published in 2016, and a revision was recently published, and they really say to use time since the index event, burden of VTE, and how severe thrombocytopenia and for how long it will be. So if you have a big PE, for example, and you're able to maintain platelets with transfusion, then maybe patients can have therapeutic doses until they're out of the thrombocytopenia period. However, if it's a distal DVT, you're unable to maintain platelets, then 50% dose, for example, for dose reduction might be okay for a short period of time while you're waiting for platelet recovery, for example. Obviously, if the platelets are less than 20, then you need to hold the low microrate heparin. But Dr. Samuels and Banal from Seattle has made an elegant review on this, and that can be reviewed with the audience as well. Obviously, as I mentioned, the further down you are from the clot, the less likely you have trouble with recurrent VTE. So if you're 1 month or more, then you don't need to give therapeutic doses because the risk of recurrence decreases over time. So half or intermediate doses or half low microrate heparin might be desirable for that. There's not a whole lot of data with direct anticoagulants for management of cancer-associated thrombosis in the setting of thrombocytopenia. It's not that it would be different or that it wouldn't work. It's just we don't have a lot of clinical experience just yet. And maybe, as time goes along and we play with the different doses of the DOACs, we'll get more used to it. But for the time being, there's no recommendation on DOACs in the setting of thrombocytopenia. And then, obviously, there's other what-ifs that we can engage with the audience. What if she's visually impaired, cannot safely administer low microrate heparin? Then it's a discussion. We know she'll be at higher risk of having major bleeding complication because of her tumor type, but the absolute difference is 3%. So having a discussion with her, or seeing if she lives with someone, can someone self-administer parenteral therapy if you decide this is the best thing to do. But if she has nebulophobia, does not agree to low microrate heparin or any length of treatment, how do you manage that with the audience? What if her disease is stable for several months, such as her chemotherapy is held? Would you consider her to be low risk? Would you stop any anticoagulation? Would you then say, well, she might be at low risk switching her if she was on parenteral drugs to direct anticoagulants? Would you switch her back to low microrate heparin when she starts chemotherapy? And then what do you actually do? What's your recipe locally about these things? So I have to admit that often when patients are on FOLFIRI, for example, have treatment holidays for summer or something, it really means that the underlying risk of tumor progression is low. Their probably risk of recurrence is probably low. I tend to hold anticoagulation in most of the patients during that time, or having a discussion with them if they do. I'm open to that discussion. We'll have a discussion with them for sure.
So, Mark, there's a question. It says, while some of the drug-drug interactions are theoretical, how do you treat when the chemo agent has a high side effect burden, including bleeding, diarrhea, nausea, and so on?
Yeah, so we'll come back to that because it's a great question. You know, it's important to keep in mind that a lot of the GI bleeding might be due to underlying GI toxicity. So it's not necessarily that the tumor is in the GI tract, but sometimes when there's ulcers or where there's irritation or mucositis or over time just erosion of the mucosa, that seems to be leading to an increased risk of major bleeding as well. So, I mean, I tend to be very careful then with direct oral anticoagulants. I'd probably challenge the patient to low microwave heparin, see how they're doing. And as the risk of recurrence is decreasing over time, then we can go back and forth depending on the underlying side effects. Is that fair, Anil?
Yeah, no, perfect. Thanks, Mark.
So let's do the second case study. It's aggressive colorectal cancer from LMWH from Richelieu in Montreal. So a 39-year-old accountant. He's married, 3 children, non-smoker, non-drinker, past medical surgical history, abdominal hernia repair and mastectomy. Previous history or family history of cancer. His BMI is 23. And he presents to the emergency room with 1-week history of shortness of breath and cough, not responding to oral antibiotics, and a normal CBC initially with a good platelet count. He has slight increase in his PT and INR. GFR is good, and he has a C8 that is 4.8. So the CT scan of the chest showed enlarged metastatic lymph nodes, right hilar lymph nodes, retrocranial lymph nodes, right middle lobe bronchofascicular thickening. He's referred to ENT for a diagnosis and biopsy. A few days later, he presents to the emergency room with re-diagnosed right upper extremity swelling and pain for 2 days. He has a proximal upper extremity deep vein thrombosis, so clot in the axillary subclavian internal jugular vein. And then that begs the question at this particular point in time, if you hadn't read the initial case of what will be the underlying diagnosis or the title slide, what would you do? Would you hospitalize him? And that's a way to, generate discussion about decision on hospitalization, not necessarily for burden of VTE, but also facilitating diagnosis, for example. Would you use one of the low microwave heparin? Would you use vitamin K antagonists, or would you use one of the direct oral anticoagulants? So in this particular case, Mr. NN, he's treated with therapeutic dose low microwave heparin. He felt that it may be easier to manage in the perioperative period because you need to have a fine needle biopsy of the right neck that is done on March 22nd, which showed adenocarcinoma from colorectal origin. And then said, he has this C-scope afterwards that confirms the proximal transit colorectal carcinoma. So the next step on April, he has new right upper extremity symptoms, worsening of the swelling. The Doppler confirms extension of the previously described thrombus, so this is a risk of recurrent VTE despite anticoagulation. It's not unusual, right? We've seen the risk of recurrence, so 1 in 10, 1 in 20 patients will have them depending on the agent. Patient has been compliant with the low microwave heparin injection. That's not the problem. There's no heparin-induced thrombocytopenia. It's a little bit further down the road, but always important to keep in mind. And the decision is to increase the dose of low microwave heparin up to 125%. And this is just to generate discussion about recurrent VTE despite anticoagulation and what to do. So there's some guidance from the American College of Chest Physicians that if you're already on a subtherapeutic dose, like a 50% or prophylactic dose, then that's easy. You switch them up to 100%. If you're already on a therapeutic dose, let's say that you're on normal microwave heparin at a certain pre-filled syringe, then the recommendation would be to increase that from 20 to 25, and usually the next pre-filled syringes. But it's important to still see your patients. You need to reassess them in 5 to 7 days, make sure that symptomatically they're starting to feel better. And if so, then you continue the same and you resume your usual follow-up. But if not, then maybe additional imaging down the road might be important. Some of these patients need to see a lot of anticoagulation. They have a lot of non-specific bindings to proteins that can lead to decreased efficacy of some of the anticoagulants that we usually use. The ACCP also has some recommendations. So what if this has happened if you picked rivaroxaban or edoxaban, for example? There's not a whole lot of data. Some data is ongoing or studies are ongoing. Right now, the guidance from the American College of Chest Physicians would say to switch to low microwave heparin at a therapeutic dose for at least 4 to 6 weeks and then reassess at this time afterwards. Now, for the last case study, it'll be lung cancer-associated venous thromboembolism, so a lung cancer case coming from Peter Cavan from McGill University. So 56, Mary de Curlis from Ontario. So 56-year-old theater producer, divorced, 2 teenage children, active, 50-pack-year smoker, the occasional THC. It's now legal, so it's all good, no alcohol. Reports reduced exercise tolerance, lately limited by dyspnea, no previous medical history, no current medication. The BMI is 26. We present the emergency room with a PE, so right-sided thoracic chest pain. He's not tachycardic. Satting is 93%. He's breathing a little bit quickly. Blood pressure is 140 over 80. He has sinus rhythm with right ventricular strain. Chest X-ray showed hyperinflation, possible right upper lobe mass. CNI is positive. CTP shows bilateral segmental embolism in the right middle lobe and left lower lobe. There's presence of right apical mass, possible mediastinal evasion, neutrophilia on CBC, renal and liver function are well, and well-established lung mass, follow-up outpatient program. The patient in the emergency feels a little bit better after anesthesia, has a big play tomorrow night, wants to go home, so what do you do? Should you admit this patient? Should you agree with him and he can go home to attend his activities? And that's to generate discussion again with the audience and maybe revising the PESI and the simplified PESI and see what the score that he would have and what would be his risk of adverse events early, but also at 30 days, and then making a decision it'd be easier to admit this patient for expediting the results, or if the patient, and for observation because of his underlying PE, or can he be safely discharged home. Obviously, when we look at his PESI score, he's class 4, so he has 11% 30-day mortality overall, if you put all the points together. So what do? Do you admit him? Do you discharge home on normoxide heparin, on vitamin K antagonist, or directional anticoagulant? So again, to generate a little bit of a discussion with the audience, and depending on the resources that you have locally, right? This will be very different if you have an active thrombosis clinic that may see the patient the following day versus you have to rely that someone will see this patient in the next few weeks, a family doctor. So that will engage discussion with your audience about what should be done locally for that. So we have mild COPDs on the PSC. The PET scan confirms the finding. Thoracic MRI confirms that he has mediastinal contact, apical invasion, no bronchial plexus involvement. He has endobronchial ultrasound at his schedule. And then depending on what the audience picks, what would be your procedure anticoagulation recommendation? If he's on low microwave heparin, when would be your last dose? Does this patient need an IVC filter or not? If the patient is on a directional anticoagulant, there's high or low bleeding risk pre-procedure, you need to stop for 3 or 5 half-lives beforehand, and is that too much, or can you tailor it accordingly? So again, just to discuss, then he needs to have a transthoracic needle biopsy, so a little bit more invasive procedure. Would that change your peri-procedural anticoagulation recommendation? Is this a point where you would need to hold it for longer, decide to put an IC filter depending on when this is done in regards to the index diagnosis? Does it matter if he has DVTs or not? And what approach would you do, since you can confirm the squamous cell carcinoma is ready to be discharged home, he's now stable? What type of anticoagulants would you use? Because he doesn't have a high bleeding risk type of tumor. Would you look at additional risk factors or not, or would you prefer to use a parenteral or oral anticoagulation? Well, obviously drug-to-drug interactions will be important, and that's why we put the preoperative, so the neoadjuvant type of chemotherapy with cisplatin and topicide. He has chest radiation as well, and he's planned for surgery in 10 to 12 weeks. So that would be a nice time for you to use these slides in discussion with the audience about what will be the peri-op plan in 3 months. Does it still need it? Does it need to have probe dose afterwards or back to the therapeutic dose? And what will be the perioperative anticoagulation recommendation at that point in time? So after 3 months, he has seizures. His CT head shows necrotic left frontal parietal brain metastases. He has no signs of recurrence on thorax and abdomen. Would you change the type of anticoagulants? You know, there's some anti-seizure medication that may interact with the rectal anticoagulants. Would that affect what type of anti-seizure medication you would use or not? Would you, for example, more likely to use Keppra instead of phentoin, for example, or would you use an alternative form of anti-seizure medication? Would you avoid DOACs and prefer to use a parenteral low microwave heparin? Is the fact that he has a single brain metastatic disease making a big difference? Do you feel comfortable about full dose anticoagulation with patients with brain mets? And, you know, in order to generate discussion, we've also added some information about primary and metastatic brain tumors on anticoagulation, making sure that you know, the audience is aware of the risk of having VTE complication, the fact that the American Society of Clinical Oncology would recommend to still use full-dose anticoagulation. Most of the data around this is not very good. Most of the data is looking at vitamin K antagonists or low microwave heparin. Some of the data will stratify if it's primary tumor versus metastatic disease. But at the end of the day, for most primary brain lesion or primary tumor, the risk of spontaneous bleeding is acceptable unless there's additional bleeding complication. And this is a systematic review by Jeff Zwicker and colleagues from Boston, just showing that if it's intracranial metastatic disease, the risk of intracranial hemorrhage, if you're on oral anticoagulation or low microwave heparin versus not, is very similar with an odds ratio of 1.07. Different cup of tea if they have glioma, because obviously they need surgeries and they're more likely to have bleeding complication. I think it's still probably, you know, it's probably the benefit of anticoagulation probably outweighing the risk associated with it. And just again, some data to show you that in that particular context. We talked about metastatic disease. This is for gliomas. So I was mentioning for gliomas, different type of T, odds ratio of about 3. But when you keep a glioma patient on anticoagulation, I know on the phone call there's folks that looked at this in very much detail about the risk of a recurrent VTE and management of VTE in glioma patients. I think the risk of bleeding is high, but it needs to be balanced with a risk of recurrent VTE that is also very high. So a case-by-case discussion is certainly desirable. So for Mr. JD, at the end of his 9 months after brain surgery, he has infill recurrence in the brain, has developed progressive left lower limb palsy, still an anticoagulation depending on what the group has decided, and he has further brain radiation. And at this time, you know, his condition worsened and he goes to hospice. So when he goes to hospice, what do? Do you stop anticoagulation? Do you decrease it to prophylactic dose? Do you have a discussion with the patient? the time to decide to stop anticoagulation depending on patient's preference. So all these things can be discussed with the audience at that time, because going from acute care to hospice or palliative care is a transition for which there's very limited data, but for which patients have strong preferences. So in a case-by-case discussion is probably recommended in most cases. The slide deck is finishing with anticoagulation continuing beyond the initial 6 months. We talked about acute, long-term treatment, initial 3 to 6 months, but a lot of patients will have underlying cancer, ongoing treatment, will need to have anticoagulation at extended duration based on, a risk of recurrence that is very high. Beyond 6 months, the option is often low molecular weight heparin because there's a little bit more data with it. There's the CAT study, the dalteparin study showing that the risk of bleeding and recurrence in the month 6 to 12 is similar to the month 1 to 6, as you know, but there's also no reason why a direct oral anticoagulant would behave differently. We'll have more data, I'm sure, from the Hokusai VTE cancer patients, but continuation of anticoagulation beyond 6 months is something that is important to consider, and having the same discussion that you have whenever you're reassessing your patients on a 3 to 6 month basis in the acute treatment period will be important. Now, of course, if they're cancer-free, they no longer have additional risk factors, then anticoagulation can be discontinued after the 6 months of anticoagulation. So the whole slide deck that you can tailor, you don't need to show everything. I've shown you everything we have today. Is just to trying to tailor your needs and what your audience will need when you present it. But as a key summary, it was really to emphasize on the new data. There's more arsenal now in our toolbox for management of cancer-associated thrombosis. One would have liked to say that's easy as we used to use parenteral for everybody. Now we can use oral for everybody, but unfortunately it's not that black and white. There's a lot of shades of gray, and there's a lot of considerations. It's important to look at tumor types, additional risk factors for bleeding, drug-to-drug interaction, and maybe having a discussion with your pharmacist when we're not aware, keeping patient's preference, insurance coverage, and the additional risk factors that need to be done on a case-by-case basis, like extreme of body weight, for example, or additional risk of recurrence because of known thrombus failure or other things are important to keep in mind. So with that, I'll just stop. I'll open up for discussion. There's 5 minutes left. I know you guys are all busy. I know Rufero and Stephanie are in Newfoundland. It's very late for them. So I'll open it up for discussion. Again, this is a slide deck that will be available for you to use, and I hope you'll find it useful. There's a few additional slides on risk factors, so depending on how keen your audience is or how deep their knowledge on cancer-associated thrombosis, you'll have a look at these supplementary slides, and you can add a few things for risk factors as well.
Okay, anybody want to ask a question on chat or on phone, please do so now. So, Mark, I guess while we're waiting, so my question would be, so you've got, let's just say, a solid tumor, a patient, a lung cancer metastasis patient who is needle phobic or for whatever reason is unwilling to start injections or wants to get off injections much more prematurely than maybe you had in terms of your care plan, and there's no other associated considerations like renal failure or excessive weight, which DOAC would you reach for?
Yeah, so that's a good question. So currently we only have data for 2 of the DOACs, edoxaban and rivaroxaban. Currently, edoxaban is not covered by most provinces. It's covered if you have private insurance. So if you're the type of person that likes to use what is the best data, I would say you probably would want to consider edoxaban, but you might be limited by coverage. So if that is the case, then there's data with rivaroxaban as well. We went through the randomized controlled trial data with rivaroxaban, but there's a lot of observational studies, especially coming out of the U.S. with rivaroxaban as well. So that might be my second choice. Obviously, apixaban is always appealing, but we don't have any data yet with apixaban for cancer-associated thrombosis. There's one trial called the Caravaggio trial that is ongoing. The results will probably be available in about 18 months. And there's really no data whatsoever with the dabigatran. So, probably the dabigatran I would rule it out because it's also a bit more dependent on renal clearance. So because of the lack of data and the properties, that probably would not be my first choice. But, I would probably start with edoxaban because that's the best data, and then if not possible, then rivaroxaban or consider rivaroxaban. I would wait a little bit for apixaban. Is it a class effect or not is a whole discussion, but these would be my two first picks, I guess.
Excellent. Does anybody else on the line or on the chat want to ask a question for Mark? Okay, then I think we're just towards the end. We've only got about 5 minutes left, and I think I wanted to thank Mark very much for a very informative presentation. And then, as David said, this webcast has been recorded, so I guess it can be viewed in the future. People have the slide decks. And David, did you have any other remarks?
Sorry, there is one other question here. I don't know if you've seen it. From Marie-France Gauthier, maybe I missed it but the question is, when you decide to use a DOAC for CAT, do you have a preference for edoxaban given the bigger sample size pilot study for rivaroxaban, or do you feel the use of rivaroxaban is reasonable? Keep in mind coverage of edoxaban is limited.
Right. So I think we sort of touch about it a little bit about it in the previous question, David. So I think I would, I agree with Marie-France. There's probably more data with edoxaban. That'd probably be my first choice. Due to lack of coverage, then I think rivaroxaban is probably very reasonable.
All right. Well, with that, I want to thank both of you for participating tonight and presenting the presentation. It was a great presentation, and on behalf of Thrombosis Canada, thank you both. And we also want to thank Sanofi for providing unrestricted funding to help develop and deliver this presentation tonight. And thank you all for participating in this event.